Next talk, Managing Giant Retinal Tear, Tips and Tricks, Tariq Ali from Dhaka, Bangladesh. Long time, our friend. Tariq, please.
So good morning, respected Chairman and that is our audience. At the last day, I'm very much fortunate to be here, and I must acknowledge my gratefulness to the organizers who have allowed me to be here. My talk is Managing GRT, Tips and Tricks, No Conflict of Interest. GRT, we all know that full thickness circumferential tear more than 90 degree associated with usually vitreous detachment. It can occur spontaneously, but usually associated with number of conditions. It is around 1.5% of all rheumatogenious RD is giant retinal tear. Average age was found around 42 years. Cause, as I told, idiopathic, high myopia, hereditary some conditions, Marfan's Sticklers, trauma, and incidence was found in USA 0.05 by 1 lakh per year. Pathogenesis is liquefaction of the central vitreous and peripheral vitreous condensation, which causes concomitant traction at the vitreous base, and neurosensory retina tears circumferentially in the area of the posterior vitreous base. And PFCL management was much better after the invention of PFCL, which was first described by Stanley Chang in 1987, and increased the primary attachment rate from 58% to 94%. And we have other options like laser photocoagulation, scleral buckle, primary vitrectomy with PFCL, vitrectomy plus buckle, or combined phaco plus vitrectomy. Laser we can do in some cases where edges of the tear is treated with 2 to 4 layers of photocoagulation. Scleral buckle we can do if the edge is not inverted. And usually you go for PPV, pars plana vitrectomy with PFCL with silicone oil tamponade. Surgical techniques, as we know, that removal of the vitreous posteriorly and injecting the PFCL, and it is done very slowly with a double bore cannula, and PFCL should be given as a single bubble to prevent the fish eggs. Once the retina is stabilized, then anterior vitreous and the anterior retina flaps are removed, and chandelier illumination you can take, and it is very much paramount to remove all the vitreous, especially in corners to prevent the redetachment. Then we put more PFCL up to the edge of the tear, and PFCL level should be kept below the infusion cannula to avoid the formation of fish eggs. And retina can be unfolded with the forceps or with your vitreous cutter. All of the anterior flap and vitreous need to be thoroughly removed, especially all possible case of vitreous you should remove. This is a case of giant retinal tear. You see, we are removing the vitreous, and in this case, usually posterior vitreous is always detached, usually. Here also it was detached, and we are removing all the vitreous throughout the retina, and our assistant actually, he will help us to remove the vitreous along the vitreous base. We are removing that is all the vitreous which is attached. Base shaping is very much important in the attached part of the retina, and simultaneously you have to find is there any other detachment, any other break is there or not. So we have to remove all the vitreous around that break also. This is the break you can see, and here these edges of the breaks, we are removing the vitreous very clearly, very nicely. We have to be very meticulous in this position actually. Then after this unfolding, you can do by manually, that is we are doing with our vitreous cutter by the, that is by low vacuum, we are unfolding the retina here. And this unfolding you can do with your forceps also, or soft tip cannula is also possible to unfold. And after this unfolding, you have to put PFCL to attach the detached retina. Yes. After this position, then we have to go for PFCL, and at first very slowly over the disc, and then we have to go inside that, that is bubble, so that we can slowly increase the PFCL to attach all the retina, and it should come under the crystalline lens. Then very good laser is very much important. And here we did PFCL silicon oil exchange in a same sitting, that we'll remove the PFCL and put the silicon oil. You can see. It is also possible to do the fluid air exchange and then put the silicon oil. That is also possible. And aspiration of all fluid, and you have to keep your tip very close to the brake so that there is no slippage. This is another case. This was then that is pediatric case, and you see here that posterior vitreous detachment was not there. It is surprisingly posterior vitreous was not detached. So we had to remove this posterior vitreous very cautiously, so that there is no other break we are forming. After this removal of the vitreous, then the procedure is similar. Here you see all the vitreous we have to remove, and we can put, that is triamcinolone, to see the vitreous. Here we are putting some PFCL to stabilize the posterior pole, and then we will go to the anterior flap where vitreous is very much adherent, and we have to remove that anterior vitreous along the anterior part of the retina also to remove all the tractions. This is pediatric case, as I told, so we cannot keep any single amount of vitreous, otherwise it will create redetachment. Yes, this is the anterior flap. We are removing the vitreous, and then silicone oil and PFCL silicone oil exchange and laser, everything is done, and retina was attached. Here, as I told, the retinal margin is folded over itself, so we have to remove, trimming the rolled part, which is not unfolding. So this is the trick that, well, we'll go for PFCL silicone line exchange. You can do simultaneously, or as I told, that you can do fluid air exchange, then put the silicone oil. But here, slippage is possible, so I prefer to go for PFCL silicone oil exchange. So I'll go to the last slide that we have, that is known about the PVR. Everything has been told already. GRT is a very complex situation. Sometimes it is blinding condition. It needs early treatment, and modern vitrectomy tools and techniques with wide-angle viewing system, chandelier illumination, and invention of PFCL has made our work very easy to attach this that is a very complex situation. Thank you, ladies and gentlemen, for your patience hearing.
Thank you, Tariq. Yes.
Hi,
yes.
I have a question. Do you think on your incidence slide, where it said 12% incidence of Sticklers and Ehlers-Danlos, that incidence is actually low, that's actually truly higher than that with giant retinal tear patients who present 45 years old or younger with no history of trauma? Because to me, in my experience, when we test them genetically, a lot of the patients, they don't have the classic facies or double jointedness or chest abnormalities or cleft palate or other things that we associate with Stickler syndrome, have genetics that are positive for Stickler syndrome.
Of course, but in my cases, what I did, that is that there was no case of Stickler, but I found it from the literatures that I showed. Yes, you are very much correct. That yes, incidence.
And that's important because then
yes.
you prophylactically treat the fellow eye with laser, or as you mentioned earlier, possibly with scleral buckles in some cases.
Yes.
Absolutely, I think that is very important. The fellow eye, looking at it and treating it, because many of these cases, especially younger ones, with giant retinal tear, you will find suddenly the other eye going into that. So
Yes,
I
sir.
think that part one has to keep in mind. And also, I think two things which I wanted to just mention. One is, what about the anterior flap? Are you trimming that, the anterior part, because most of the time that needs to be trimmed?
Yes.
Because otherwise that can, because that you have not shown in your kind of
It's in the
cases.
second case I showed
Yeah.
that the anterior flap you have to remove, otherwise the vitreous is attached there. That
Yes,
will
because
cause
not only vitreous, but this flap itself can create problem later on, and it may get even attached anteriorly, and you have a problem with the. And most of the way you were injecting PFCL, mostly we tend to remain more nasal rather than going over the posterior pole, like what you were showing in the video sometimes, because you never know. Sometimes it is if a little more force is used, so that we might have a issue with that.
yes, yes.